Okay, I'm not going to spend too much time on this slide. Uh, this is basically taking a health history for the cardiovascular exam. So common, symptoms that they may have, past medical history such as angina, family history such as such as heart attacks or atherosclerosis, medications that they take, so cardiac medications, their general nutrition, activity and exercise, and so on. Okay, so this is just a general health history. Okay, so when we're looking at chest pain, so someone comes in with the symptom of chest pain, that can be from an assortment of conditions, right? So let's look at a couple here. There's more than this, but let's just look at some here. So hiatus hernia or gastroesophageal reflux disease. Hiatus hernia just means that some of your stomach has herniated, is in your chest. That's all a hiatus hernia means. Gastroesophageal reflux disease means you're refluxing acid into your esophagus, and that can irritate your esophagus and cause typically burning chest pain. Okay. Bottom left, well, those are occluded or blocked coronary arteries causing anginal symptoms. Okay, and we obviously really want to catch this one when someone comes in with chest pain. So varying degrees of, um, of coronary artery occlusion will lead to either stable angina, unstable angina, an NSTEMI, or a STEMI. Okay, and patients often come in with heavy chest pain. Um, it often radiates to the neck or to the jaw or to the shoulders. They'll often come in um, complaining that it's difficult to walk up a hill without getting chest pain. That's for stable angina, by the way. Unstable angina, they'll come in and say, usually I have stable angina, but now I'm getting it very frequently and all the time, and I'm just sitting there. I'm just resting. That's unstable angina. It means the plaque is occluding the coronary artery even more. It's not a heart attack, though. Their troponin is still normal. And then finally, NSTEMI and STEMI are myocardial infarctions, right? So again, the chest pain can be retrosternal chest pain in the front. It can radiate to the back. It can be in the upper stomach, the epigastrium. It can radiate down the left arm, or it can radiate down the right arm. Okay, so coronary artery occlusions will lead to chest pain because of lack of oxygen to the myocardium. Okay, what else can cause chest pain? Well, a pneumonia can definitely cause chest pain. Often they come in with coughing, fever, shortness of breath, plus they have some chest pain. Okay, a pulmonary embolus, where a clot has broken off from a deep vein thrombosis and traveled to the lungs. Well, that's going to typically result in pleuritic chest pain. It hurts to take a deep breath. Often they're short of breath. They may have an associated swollen leg from the DVT. And sometimes they'll cough up blood. Okay. Pericarditis is inflammation of the pericardium. And this particular cause of chest pain is usually quite harmless. It's usually caused by a viral illness. And what it is because of the inflammation of the pericardium, they often come in with central chest pain, and they have a very specific symptom associated with that. When they lie down, the chest pain is worse. When they sit up and lean forward, the chest pain gets better. And it's typically pleuritic chest pain, meaning when I take a big breath, it hurts at the front part of my chest, the anterior chest. Okay. And the reason it hurts when they take a deep breath is when you take a deep breath, more blood comes back to the heart and it stretches the pericardium, which is inflamed. And they say, I have pleuritic chest pain. Or they say it hurts when I take a deep breath. Okay. and it feels much better when I lean forward. Anxiety, panic, attack. Costochondritis is just irritation of the joints that attach the anterior ribs to your sternum. So someone who's been doing a lot of mechanical work or lifting, or they may have costochondritis. And when we palpate the ribs, they say, oh yeah, that's where it hurts. There's other causes too, though, right? A collapsed lung, a pneumothorax can cause chest pain, right? So these aren't the only causes. These are some of the common ones that we look for. Okay. So definitely anyone who comes in with chest pain is going to get an ECG. We're going to get blood work. Okay. Looking for an elevated troponin. In terms of if we think it's a pulmonary embolus, we may order a D-dimer, or we may order a CAT scan with dye, so a CTA of the chest, looking for a pulmonary embolus. Okay, so it just depends on what we think is happening in terms of the chest pain. Okay, so let's spend a bit of time on this slide. Cardiovascular assessment, so a physical exam, right? So most of the time we're thinking blood pressure, heart rate, maybe capillary refill, but let's just go through this a bit. So in terms of general appearance, are they awake, right? So if your blood pressure is low, you're not going to perfuse your brain very well, and you're going to have a reduced level of consciousness, right? So it's important from a cardiovascular point how the neurological system is doing, because it's relying on the blood to feed it, right? So people that have reduced cardiac output or low blood pressure, it's going to impact their level of consciousness and their mental status. Okay. The neurovascular assessment of skin and extremities. So those 6 Ps are usually for either typically an occluded artery to a limb. Okay, so they don't really apply to, say, chest pain or a myocardial infarction. Let's say you have a blockage to your leg, an arterial blockage to your leg from, say, atherosclerosis, or an embolus traveled, say, from your heart due to atrial fibrillation, and it lodged into your femoral artery. Okay, so now your leg is blocked of blood. Okay, so it's what's called an ischemic leg. Well, if there's no blood supplied to your leg, you're going to have severe pain because things are dying. Muscle, nerves, tissue is dying. There's going to be severe pain. The leg's going to be pale, right? Because of the lack of blood supply. It's going to be pulseless. Again, because of the blocked artery, we're not going to feel distal pulses, say at the ankle. Paresthesias, because the nerves are starting to die. So you're getting pins and needles. Poikilothermia is just a fancy term for temperature. So you're going to have a cold limb. And lastly, paralysis. The muscle has died and you now have paralysis. So that's where those 6 Ps come into, okay? For an arterial blockage, typically of a limb. Blood pressure, very important. So we want to know the systolic and diastolic blood pressure, which is what we get with our blood pressure cuff. We want to know orthostatic pressures, meaning what's the blood pressure when the person is supine, lying down, and what's the blood pressure when we get them to sit up and then stand up and check it. And do they have orthostatic symptoms, meaning when they stand up, do they get dizzy, off balance, as if they're going to fall over? That can be an indication that their blood pressure is low. They have orthostatic low blood pressure, okay? And that can happen in dehydration. That can happen if someone's taking too much antihypertensives. That can happen if someone's bleeding from somewhere. They have orthostatic hypotension. Your mean arterial pressure is really just to get, it's just trying to get an overall average blood pressure. So how do we calculate mean arterial pressure? Well, most of the time, you're actually in diastole, okay? So your heart contracts in systole and it relaxes slower. So 1/3 of the time you're in systole and about 2/3 of the time you're in diastole, okay, on average. So what we take is your systolic pressure and we add it to twice your diastolic pressure and we divide by 3. Okay, so it's taking your average pressure, your mean arterial pressure. Okay, the pulses, the peripheral pulses, we can determine the heart rate, we can determine the rhythm. Is it nice and regular? And we can tell the amplitude of the pulse, meaning is it a really weak, thready pulse, say in hypotension or if someone's severely dehydrated, or is it a nice bounding pulse that we should normally feel, say at the wrist? Your JVP, jugular venous pulsations, so we put the head of the bed at around 30 degrees and typically between 30 and 45 degrees, not straight up. And we're looking at the neck veins. And what we really want to see is there elevated JVP? So if there's an elevated JVP, it means that the blood isn't draining back to the heart very well. Why would that be the case? Well, what about congestive heart failure, where the right ventricle just can't accept all the blood that's coming back to it because it's also failing? What about a massive pulmonary embolus that's stuck in your pulmonary artery? Well, that's going to result in backup of blood into the right ventricle and into the venous system, causing an elevated JVP. Okay, so just think of an elevated JVP as something is blocking the regular flow of blood from the right ventricle to the pulmonary artery and then back to the left side of the heart. Okay, so let's just go some of these physical assessment signs or symptoms. So hemoptysis. So the more you hear about what causes all these things, the better you are off later on. Okay, so hemoptysis. Well, what can cause hemoptysis? Well, coughing up blood. Okay, so lung cancer, a pulmonary embolus. Sometimes you cough up a bit of blood, some frothy blood in pulmonary edema. Okay, so as soon as you see hemoptysis, you should think, okay, this could be a pulmonary embolus. I should think of maybe congestive heart failure with frothy pink looking sputum, or lung cancer. Okay, sometimes tuberculosis. You can cough up some blood. So hemoptysis is usually a concerning symptom. Okay. What about the coughing? In terms of coughing, so many things can cause cough. So let's start at the top with a benign condition called acute bronchitis. Acute bronchitis is just a viral infection of the bronchial tubes. It typically resolves after 7 to 14 days, no matter what we do. Okay, because the vast majority of them are viral. COPD, chronic obstructive pulmonary disease. Well, they cough up. They cough a lot. They have a chronic cough. They have purulent sputum, and they're often short of breath. Okay. What else can cause coughing? Pneumonia can cause coughing. Okay. You're trying to hack up all the phlegm that's in the alveoli and in the lungs. Okay. In terms of cardiac, you can get some coughing with pulmonary edema, so congestive heart failure leading to pulmonary edema. Sometimes patients are coughing, but they usually have a whole bunch of other signs of the congestive heart failure. Crackles in the lung. So crepitations and crackles can be an indication of fluid in the lung. Okay? So if we were to listen to someone's lungs and on the left and the right side, they have crackles and crepitations, that can be an indication of congestive heart failure. If they have isolated crackles and crepitations in just one area of one lung, then we're going to think of something more focal, such as a pneumonia. Okay? Wheezing almost always comes from the bronchial tubes, right? Bronchoconstriction and excessive mucus. So that can happen in asthma, that can happen in COPD, and that can happen in, say, cystic fibrosis. And it can happen in an allergic reaction. So as part of anaphylaxis, you get wheezing because of bronchoconstriction. Okay? The hepatojugular reflex. Okay, well, what's that? So we sit someone up, just like in this image here, and we get them to turn to the left. So they're sitting up at around 30 to 45 degrees. We get them to look to the left, and we're looking at their jugular vein. Okay, and then we press on their liver in the right upper quadrant. And if the jugular vein just fills with blood when we press on the liver, that's an indication that the right side of the heart, the right ventricle, is not able to accept a lot of blood volume, and it's just filling back up in the jugular vein. Okay, so an elevated or a positive hepatojugular reflux is an indication of congestive heart failure, because the right ventricle cannot accept all the blood that you're trying to that you're pushing back into the heart by compressing the liver. Okay, so, and it just ends up in the jugular vein. Okay, I'm going to leave this slide to you, just abnormal, just heart murmurs. So S1 and S2 are normal. And really, these sounds are coming from the closure and opening of valves, right? And then you get into abnormal heart sounds, which typically are murmurs of some kind. So I'll let you listen to them. I'm going to tell you, in real life, it's very hard to distinguish any of these murmurs. It's so hard to distinguish mitral stenosis from, say, another type of valvular disease. Okay, so that's why we rely on an echocardiogram heavily. If we hear a murmur, we'll get an echocardiogram, which can look at the valves, and it can actually look at the flow of blood through the valves. Okay, so if we hear a murmur, yes, we can try and predict it's the murmur of aortic stenosis, or it's the murmur of mitral regurgitation, but we need to confirm it, and that's with an echocardiogram. Friction rubs. So you can have a pericardial friction rub in the case of pericarditis, because there's inflammation of the pericardium, and the two layers of the pericardium are rubbing against each other. It almost sounds like sandpaper. So pericarditis can cause a friction rub. You can have a friction rub of your pleura. So if you have inflammation of your pleura from a condition called pleuritis, which is typically caused just by a virus, when you're breathing, when you're inhaling and exhaling, sometimes we can hear the friction rub of pleuritis. Okay, so that's all a friction rub means.